I want you to picture a patient. They've been sitting in your waiting room for about 25 minutes now.
Right. And their mobile phone battery is probably hovering at 12%.
Exactly. 12%. They are checking it constantly. They had to leave work early to make this appointment, navigating mid-morning traffic, endlessly circling the multi-story car park for a space, and rushing into the clinic only to be told by a receptionist to just take a seat and wait.
And the anxiety is already building before they've even seen a clinician.
Completely. I mean, they are not entirely sure what's going to happen today. They don't know whether the MRI results they're about to discuss with you are going to fundamentally alter the trajectory of their life or their career, or even just their basic mobility.
Yes, the stakes for them are incredibly high.
They are. They're anxious, they are very likely in physical pain, and crucially, they are silently internally debating whether to reveal an embarrassing, highly vulnerable symptom to you, a decision they actually haven't finalized yet.
Well, that is the precise reality of the modern clinical environment, isn't it? It's a pressure cooker. It's a pressure cooker of unspoken anxiety and physiological stress, which is completely hidden behind this polite, quiet demeanor in the waiting area.
Right, the classic British stoicism on the surface.
Exactly. So when you finally open that door, you are not merely walking into a room, you are intersecting with a highly activated neurobiological state.
And that is the person you walk in on. But here is the critical pivot of our entire discussion today. The very next 60 seconds, the exact minute following the opening of that consultation room door, will dictate a remarkable amount about what happens in the rest of the visit.
It is the most consequential minute of the encounter.
It really is. In fact, our framework today highlights that what happens in those initial 60 seconds is a higher predictor of whether that patient will eventually file a formal malpractice complaint against you than your actual surgical complication rate.
Which is a staggering statistic when you first hear it.
It's mind-blowing. Those 60 seconds determine whether they tell you the real issue, whether they trust your clinical recommendation, whether they actually adhere to the post-operative treatment plan, and ultimately whether they leave the hospital feeling as though they were heard by a physician or just sort of processed by a massive indifferent system.
Processed like a barcode.
Yes. So our mission for this deep dive is to completely dismantle the archaic concept of bedside manner.
Yeah.
We need to stop viewing this as some innate personality trait or this vague charisma you're either born with or you lack.
Right, it's not magic.
No, it's not. We want to reframe the opening of a patient encounter as a highly designable, structured clinical mechanism.
And what's fascinating here, really, is the sheer asymmetry of leverage. I mean, if you think about our training in orthopedics, and indeed across all surgical and medical specialties, we obsess over the micromechanics of our procedures.
We absolutely do.
We spend decades, literally decades, refining the exact angle of an osteotomy, the precise tension of a suture, the optimal placement of a pedicle screw. We train for thousands of hours to master interventions that occur while the patient is completely unconscious.
Yes.
Yet the initial 60 seconds of a conscious consultation are frequently dismissed as a mere preliminary, a so-called soft skill that simply precedes the actual medicine.
The preamble to the real work.
Precisely, yeah. But if we examine the clinical data and the psychological realities of patient care laid out in our discussion material, we are forced to establish a radically different foundation. The first minute is not a soft skill at all.
No.
It's one of the highest leverage, most consequential interventions in clinical practice. It's completely trainable, it is entirely measurable, and it possesses direct, profound, downstream consequences on both the patient's physical outcomes and, frankly, the clinician's longevity in the profession.
Which brings us directly to why you, the listener, the mid-senior medical professional running a heavily overbooked, inherently stressful clinic, should care about this.
Because they are already exhausted.
Exactly. You might be sitting there thinking that you simply do not have the time to worry about the choreography of your entrance when you have 30 patients on the list and the trauma ward is paging you relentlessly.
It feels like one more thing to do.
It does. But mastering this specific architecture is an act of professional self-preservation. It prevents those formal complaints. It avoids the immense friction of unnecessary second opinions. And perhaps most importantly for your own survival in this profession, it fundamentally changes how drained you feel at the end of the day.
It stops the slow bleed of your energy.
Right. So let's tackle this damaging myth head on. The myth of the soft skill. Communication in medicine is universally categorized this way, and I would argue, based on our text, that this is one of the most destructive phrases in our entire field.
It is deeply destructive because, well, in any high-stakes profession, Language dictates priority. When we label a competency as soft, we implicitly marginalize it.
We demote it.
Exactly. We signal to medical students, registrars, and even seasoned consultants that communication is an optional garnish on the side of the main dish, which is clinical acumen.
The parsley on the plate.
Right. We tell them, effectively, that as long as your diagnostic reasoning is sound and your surgical hands are steady, how you speak to the patient is merely a bonus for customer service scores.
Which is so dangerous.
Extremely dangerous. Because if we analyze the empirical reality of medical practice, there is absolutely nothing soft about the downstream effects of those first 60 seconds. These opening moments establish the psychological safety required for a patient to actually disclose the true nature of their symptoms.
Because if they don't feel safe, they hide things.
They absolutely hide things. Without that disclosure, your diagnostic accuracy plummets. You cannot diagnose a symptom the patient is too intimidated to share.
I look at it through a very specific analogy. Okay, let's unpack this. Calling the opening 60 seconds of a patient encounter a soft skill is, to my mind, entirely equivalent to calling the sterility of a surgical scalpel a nice to have.
Oh, that's a brilliant way to frame it.
Right, because you would never in a million years say, well, the consultant's technique was flawless, the alignment of the implant was perfect. It's just a bit of a shame the instruments were contaminated with staphylococcus.
The patient still loses the joint.
Exactly. The scurrility is not an optional extra. It is the absolute, non-negotiable foundation of the entire procedure. If the foundation is compromised, the excellence of the subsequent technique is rendered entirely irrelevant by the ensuing deep joint infection.
The infection ruins the brilliant surgery.
Yes, and in the exact same way, if the opening 60 seconds of your consultation fail to establish trust and psychological safety, your brilliant diagnostic reasoning, your encyclopedic knowledge of anatomy, and your perfectly tailored treatment plan are infected by patient resistance, doubt, and non-adherence.
That is precisely the mechanism at play, and it goes far beyond just the initial diagnosis. It bleeds directly into treatment efficacy. We'll consider patient adherence to complex postoperative rehabilitation protocols. In orthopedics, as you know, the surgery is often only 50% of the cure. The patient's adherence to a grueling, painful physiotherapy regimen is the other 50%.
And physio is hard work.
It's terribly hard work, and that adherence is inextricably linked to the trust established in the initial encounter. If they do not trust you, they will not comply with your conservative management recommendations, and they certainly won't push through the pain of rehabilitation. They'll just abandon the protocol.
And then the joint goes stiff, and they blame the surgeon.
Always. Furthermore, it directly correlates to the prevention of formal, legally binding complaints. When you look at the data surrounding medical litigation, an overwhelming majority of claims are rooted not in clinical negligence, but in a breakdown of communication.
Really? Not surgical errors.
Yeah. No, the root cause is usually that the patient felt ignored, dismissed, or rushed. There is nothing soft about a medical negligence claim or a catastrophic failure of patient compliance resulting in a stiff, unusable joint. These are hard, measurable, uncompromising clinical metrics.
So clinicians who recognize this, who treat the opening as a deliberate, practiced craft rather than a random collision of personalities, they must cultivate an entirely different atmosphere in their clinics.
Well, they do. Practices that implement these deliberate openings fundamentally feel different. And this feeling is not merely a warm, fuzzy, intangible sensation. It manifests as a literal reduction in clinical friction.
Friction meaning pushback from the patient.
Exactly. When a patient feels seen and acknowledged immediately, their defensive barriers lower. They stop demanding unnecessary MRI scans to validate their pain because they feel the clinician has already validated the reality of their suffering.
Ah, so they don't need the scan to prove they are hurting.
Spot on. They stop arguing with your conservative management plans. The entire consultation flows with a cooperative, collaborative momentum rather than an adversarial resistance. The investment of deliberate intent in the first minute pays immense dividends in the form of frictionless clinical delivery for the remaining 14 minutes of the appointment.
You spend your time practicing medicine rather than managing hostility?
Precisely.
So if this foundational minute is that critical, we need to understand exactly what we are walking into. We can't possibly design an effective opening without first acknowledging the profound psychological state the patient brings into the room before we even touch the door handle.
The unseen preamble.
Right, the unseen preamble. And our material outlines 3 absolute truths about this preamble. First, they have been waiting. Second, they are rehearsing a story. And third, they are subconsciously scanning you for signals.
All three of these are happening simultaneously.
Yes. Let's start with the wait. We know the clinic is a pressure cooker, but let's break down the physiology of that. How does the actual duration of the wait alter the emotional and biological landscape of the patient sitting in that plastic chair?
Well, we must first strip away the illusion that waiting is a passive activity. A
Mm.
patient waiting in a clinic is not experiencing empty time. They're in a highly active, escalating physiological state.
Active how?
The biological disparity between a 5-minute wait and a 40-minute wait is vast. At 5 minutes, the patient is still tethered to their normal daily routine. They're checking emails on their phone, they're relatively relaxed, their heart rate is essentially at baseline.
They're just killing time.
Exactly.
Mhm.
But by 40 minutes, a cascade of stress responses has been activated. They are ruminating on their symptoms, they are worrying about the parking meter expiring, they are calculating the work they are missing. But more importantly, they are feeling disrespected by the systemic delay.
They start taking it personally.
Yes. Their cortisol levels are elevated. This is not purely psychological, it is neurobiological. Elevated cortisol heightens pain perception. It narrows cognitive focus. They're actively constructing a narrative of grievance.
So the waiting room is essentially a factory for anxiety.
It's an active crucible of anxiety. When you finally open that door, you are not meeting the person who arrived at reception an hour ago. You are meeting a biologically altered, highly sensitized, chemically stressed version of that person.
That's a terrifying thought. And while they are sitting there marinating in that cortisol-soaked state, they are doing the second thing. They are rehearsing their story.
Constantly running through it.
Everyone does this. You
Yep.
sit in the waiting room staring at some old poster about flu jabs, and you mentally draft the bullet points of your pain. You think, it started 3 weeks ago. It hurts when I walk upstairs. It radiates down the lateral side of the thigh.
Which sounds very helpful initially.
Right. On the surface, that sounds incredibly helpful to us. They're preparing the history. They're doing the work for us. But the reality of this rehearsal is actually quite dangerous, isn't it? Our text suggests it acts as a defensive wall.
It acts as an immense barrier to accurate diagnosis. The rehearsed story is a fascinating psychological phenomena, and it's born out of systemic scarcity.
Scarcity of time.
Exactly. The patient creates this script because they anticipate having very little time to speak. They know the system is rushed. So they condense their complex, nuanced, messy, lived experience of illness into a tight, easily digestible, bullet-pointed monologue.
They edit themselves before they even see you.
They do. And sometimes, yes, the basic facts are helpful.
Yeah.
But very frequently, this script is a highly curated, defensive narrative designed to protect them from perceived judgment or, quite often, to force the clinician toward a specific desired outcome.
Give me an example of that in practice. How does a script force an outcome?
Right. Consider a patient with chronic diffuse knee pain. It's likely degenerative, exacerbated by weight and lifestyle factors. In the waiting room, knowing they only have 10 minutes, they curate their story.
Yeah.
They omit the fact that the pain has been manageable for years, and instead they focus entirely on a minor twisting incident that occurred a week ago when they stepped off a curb.
Because an injury sounds more urgent than arthritis.
Exactly. They rehearse a script about an acute injury because they believe, subconsciously or consciously, that an acute injury narrative is the only way to compel you to order an MRI.
Which they feel they desperately need for validation.
Precisely. Because they are so rigidly attached to delivering this rehearsed script, this protective shield, it prevents you, the clinician, from discovering the nuanced peripheral details that actually hold the key to the correct diagnosis.
The script becomes a wall.
Yes. If we do not dismantle that wall carefully in the first 60 seconds, we spend the entire consultation treating the script, treating the artificial narrative, rather than treating the underlying pathology.
And here is where the tension really ratchets up. While they're waiting, generating cortisol, and clutching this rehearsed script like a shield, they're also actively engaged in the third element, the subconscious scan.
The amygdala response.
Right. The moment you open the door, before you even utter a single syllable, their brain is automatically registering your body language, your eye contact, and your perceived level of rushedness. It's an instant primal calculation.
It is pure evolutionary biology, deeply embedded in our neural architecture. The human nervous system, specifically the amygdala, is exquisitely tuned to assess the intent and threat level of a newly encountered individual within milliseconds.
So they are judging you instantly.
The patient's brain is running a rapid subconscious diagnostic on you. Are you looking at the floor as you enter? Are you sighing? Is your jaw clenched? Is your hand already reaching for the computer mouse before you've even turned to face them?
Are your feet pointing towards the door as if planning an immediate escape?
Exactly. And the patient is not sitting there consciously thinking, the consultant appears to exhibit a closed physical posture indicating time scarcity. That's not how it works.
No, it's visceral.
Highly visceral. Their autonomic nervous system simply registers. This person is not safe to confide in. This person is not present. This person is a threat to my emotional and physical equilibrium.
Wow.
And this entire catastrophic calculation occurs before the formal clinical interview has even commenced.
Okay, I have to stop you there and represent the listener for a moment because I hear this theory and I understand the neurobiology of the amygdala, but let's be fiercely realistic here.
That's it.
I am running a trauma clinic. The 40-minute delay wasn't caused because I was drinking coffee in the staff room. It was caused because a complex open fracture came through the doors and required immediate life-saving stabilization.
A very common reality.
Right. I did not cause the traffic. I did not design the inadequate hospital parking. So if the patient arrives defensive, physically anxious, clutching a rigid script, and hypervigilant to any sign of dismissiveness, aren't clinicians starting from a severe, almost insurmountable deficit?
It certainly feels that way.
A deficit that is entirely systemic. Why is their baseline hostility, which is generated by a broken system, suddenly my individual clinical responsibility to manage?
That is the most valid, pervasive, and exhausting frustration shared by clinicians globally. And you are entirely correct. You are starting from a massive deficit. And no, you did not cause the systemic failures. You didn't cause the understaffing or the trauma case that derailed your morning.
Right. It's not my fault.
It is not your fault. However, we must separate fault from responsibility within the confines of that room. Acknowledging this unseen preamble is not about accepting the blame for the system. It's about recognizing that this highly charged emotional state is the actual clinical reality sitting on your examination couch.
You have to treat what's in front of you.
Exactly. If you walk in blind to their state, stubbornly refusing to acknowledge it because, well, it wasn't your fault the deficit compounds, the hostility remains, the script remains rigid, and the visit is ruined. You will spend 20 minutes arguing with a defensive patient, which frankly just puts you further behind schedule.
So it is about pragmatism, not taking the blame.
Precisely. It's highly tactical. You are absolutely responsible for how you intersect with their anxiety in your consultation room. If you walk in with a designed, deliberate opening that signals safety, presence, and acknowledgement, you can dismantle 40 minutes of accrued, cortisol-driven waiting room anxiety in roughly 10 seconds.
That's a massive return on investment.
It is about seizing immediate authoritative control of the emotional environment the moment the door opens. You are neutralizing the deficit so that you can actually do your job.
Okay, that makes total sense. It's a tactical intervention to clear the runway, so to speak. So how do we actually do that? How do we build this intervention?
And the mechanics of it.
Yes, that brings us to the architecture of entry, specifically the microelements of a strong opening. We're moving from the theoretical psychology to the highly practical physical execution. The text outlines 4 microelements.
And the first 2 are entirely physical.
Oh, right. The first microelement is a clear physical arrival. This critically includes making eye contact before looking at the chart and, above all, sitting down. Let's break down the actual physics of walking into a room.
The physical arrival must be executed with absolute, undeniable intention. If you watch a busy clinic, you will see how rare this actually is.
People just drift in.
Exactly. Many clinicians sort of drift into the room. They walk through the door while simultaneously reading a piece of paper or checking a message on their smartwatch or continuing a conversation with a nurse over their shoulder.
I've done that. We all have.
We all have. But this physically demonstrates a fractured attention span. You are telling the patient, without words, that you only have a fraction of my bandwidth. A clear arrival means you cross the threshold of the room, you stop your forward momentum, and you orient your entire physical presence, your shoulders, your hips, your gaze, directly toward the patient.
A complete physical stop.
Yes. You establish direct, unbroken eye contact before you even glance at the clinical workstation or the sterile field. And then, crucially, you must sit down. The psychological impact of the clinician sitting down simply cannot be overstated.
It's arguably the most powerful nonverbal tool in medicine, isn't it?
It is.
It's staggering how much power that simple change in physical elevation holds. The data on this is fascinating. Sitting down drastically alters the perceived length of the visit in the patient's mind, and it costs exactly 0 clinical time.
0 seconds.
It takes the exact same number of seconds to conduct a 10-minute consultation standing up as it does sitting down, but the subjective experience for the patient is completely transformed. Why is the geometry of sitting so potent?
Because when you stand, you are inherently communicating a state of transience. You are biologically signaling that you have one foot out the door.
Yeah.
Furthermore, you are physically looning over the patient.
Especially if they're in a low chair on the couch.
Exactly. In evolutionary terms, towering over a seated, vulnerable individual, someone who is injured, anxious, and perhaps wearing an ill-fitting hospital gown, establishes a steep adversarial power dynamic.
It's intimidating.
It is. The patient subconsciously registers this physical dominance and transience, and their reaction is to rush. They accelerate their history, they omit crucial, nuanced details, and they swallow their questions because they feel they are intruding on your immensely valuable time. They feel they are a burden.
And when you sit,
When you pull up a stool and sit down, you immediately lower your center of gravity. You place yourself on the same horizontal plane as the patient. You eliminate the looming threat.
you level the playing field.
Yes. You communicate entirely non-verbally, I have arrived. I am stationary. My forward momentum has ceased, and my attention is anchored entirely to you.
And the data backs this up.
Massively. Studies have consistently demonstrated this phenomenon. When a clinician sits, patients perceive the consultation to have lasted significantly longer, sometimes up to twice as long, and they rate the clinician's empathy and competence much higher compared to a consultation of the exact same objective duration where the clinician remains standing.
So sitting is essentially a time machine.
It's the highest return on investment of physical energy imaginable in a hospital setting.
And once you are physically grounded in the room, we arrive at the second microelement, a warm acknowledgement by name. And we have to be highly specific here. We are not talking about a generic, breezy, "Hi, how are you?" tossed across the room.
No generic greetings.
We mean stating the patient's actual name, pronounced correctly, whilst maintaining that direct eye contact. Here is where the systemic context we talked about becomes so vital.
The dehumanization of the system.
Exactly. Think about massive healthcare systems, whether it's the NHS or a colossal private hospital network. Patients spend their entire day being systematically stripped of their identity.
It's an administrative conveyor belt.
It is. They are patient number 42 in the phlebotomy queue. They are an NHS number printed on a plastic wristband. They are a date of birth recited to a receptionist behind a thick Perspex screen.
They lose their name.
Right. So the correct intentional use of their name by the senior clinician in the room is the very first moment in that entire grueling administrative day that they are rehumanized.
That is a profound and entirely accurate way to conceptualize it.
Hmm.
The modern hospital environment, by necessity of scale, strips individuals of their autonomy and their identity. They are gowned, they're prodded, they are processed through algorithms and pathways.
It's incredibly disempowering.
Uttering their name correctly is an act of profound restoration. It signifies that they are no longer an anonymized pathology on a conveyor belt. They are a distinct human being whose specific identity commands the respect of the consultant in the room.
And the preparation for that is key, isn't it?
Crucial. Taking the 10 seconds outside the door to ensure you know how to pronounce a difficult or culturally unfamiliar name is a critical component of this respect. Mispronouncing a name, or worse, reverting to a generic mate, sir, or madam, because you didn't bother to check the notes.
It just screams that you haven't prepared.
It immediately signals a lack of preparation. It signals a lack of specific care.
Wow.
Bypassing their name bypasses their humanity, reinforcing the very systemic indifference they have been battling all morning.
So we have walked in with clear physical intention. We have made direct eye contact. We have sat down on the stool, altering the power dynamic, and we have addressed them by their correct name, restoring their identity.
The foundation is set.
We have established our physical and verbal presence. Now, we must move to the content of the dialogue. This involves the final two microelements, which our text defines as context and agency.
Microelements 3 and 4.
Right. Microelement 3 is a brief acknowledgement of context. This usually takes the form of a single sentence. Something like, "Thanks for your patience in the waiting room," or "I see this is your 6-week follow-up after the knee replacement."
Very simple statements.
Exactly. Why is this single, seemingly administrative sentence so structurally important to the psychology of the consultation?
Because Context acknowledgement is the precise mechanism by which we collapse the cognitive and emotional distance between the clinician and the patient.
Collapse the distance.
Yes, put yourself in the patient's mind for a moment. They're sitting there, highly anxious, and their primary internal question is, does this doctor actually know why I'm here?
Oh, absolutely. That's always the fear.
Have they bothered to read my file? Or am I going to have to explain my entire 10-year medical history and the trauma of my injury entirely from scratch for the fourth time today?
Which creates an immense cognitive load.
It's exhausting for them. When you provide a context statement right out of the gate, say, I've reviewed the MRI of your lumbar spine that we ordered last month, and I have read the notes from your physiotherapist. You instantly relieve that massive burden of anxiety.
You prove you've done your homework.
You prove to them, definitively and immediately, that you are oriented to their specific clinical journey. You establish that you are already up to speed. This allows the patient to exhale.
They can just drop their shoulders.
They no longer have to defensively prepare to justify their presence in your clinic. And crucially, if you have kept them waiting, a genuine context-aware statement like, thank you for your patience, I know we are running 40 minutes behind today due to an emergency, well, that validates their frustration.
It names the elephant in the room.
It names it, diffusing the grievance before it can contaminate the actual clinical discussion.
It bridges the gap between the chaotic, stressful outside world of the hospital corridor and the focused sanctuary of the consultation room. Which leads us to the fourth and final microelement, the open invitation to start the dialogue.
This is where we hand over the agency.
Yes. We are strongly advised by our framework to avoid closed administrative questions like, what brings you in today? Primarily because they have already explained what brought them in to the referring GP, the triage nurse, and the front desk receptionist.
Asking it again makes you look totally disconnected.
Exactly. Instead, we should use open phrases like, where would you like to start? Or, tell me what has been on your mind regarding your hip.
Open the floor to them.
Now, I have to challenge this because I know exactly what every single overworked listener is screaming at their dashboard right now.
Oh, I know what's coming.
We live in absolute fear of an open invitation like, where would you like to start? The prevailing fear is that this will be interpreted as a green light for a 20-minute entirely unstructured monologue about their neighbor's cat, the weather, and their historical bunion surgery from 1998, which will completely, irrevocably derail a tightly packed clinic schedule.
It's the ultimate fear of losing control.
I simply cannot afford to give up control of the timeline. Is this open invitation not a recipe for temporal disaster?
It is the most common fear amongst clinicians, and it feels intuitively correct. But the clinical data and the reality of thousands of recorded patient interactions definitively refute it. It is an efficiency paradox.
An efficiency paradox. Explain the mechanism of that. How does giving up control actually save time?
Well, when you ask a closed leading question, or you immediately drive the agenda, tell me about the pain in your left knee, you force the patient to answer only the specific parameter you have defined.
Because I'm the doctor and I set the rules.
Exactly. They will answer you, because you are the authority figure, but they will hold on to their primary secret concern, perhaps a fear of cancer or a fear of losing their independence until the very last second.
You're treating the knee, but they're terrified of a tumor.
Precisely. Giving them the floor uncovers the real driving issue immediately. Crucially, it prevents the dreaded doorknob confession.
Oh, the doorknob confession, the absolute bane of every doctor's existence.
Exactly. The doorknob confession is that terrifying moment when the consultation is ostensibly finished, the prescriptions are printed, your hand is literally on the door handle to leave, and the patient suddenly says, oh, by the way, doctor, I have also been having crushing chest pain.
Or actually, the real reason I am here is I found a lump.
Yes?
And it destroys the entire schedule anyway, but it does so at the absolute worst possible time when you have zero mental bandwidth left. The next patient is already angry, and you have to rapidly triage a potentially life-threatening symptom in the doorway.
Precisely. And here is the vital insight from our material. The doorknob confession is almost always a direct symptom of a failed opening.
Really, it's connected to the start.
It is an anatomical failure of the visit. It occurs because the patient never felt sufficient agency or sufficient psychological safety during the primary consultation to raise their true underlying fear. They waited until the very last second when the pressure of the ending forced it out of them.
Because they ran out of time to hide it.
Yes. By asking, where would you like to start? And simply sitting back, you grant them the immediate authority to place their highest priority on the table at minute 1.
But won't they just talk forever? That's the fear.
The data shows they don't. Yes, they might speak uninterrupted for 60 to 90 seconds. Now, to a busy surgeon, 90 seconds of silence feels like an absolute eternity.
It feels like an hour.
It does, but let them speak. Active listening during those 90 seconds will provide you with a wealth of diagnostic clues, emotional context, and functional limitations that would take you 15 minutes to extract via a rigid interrogative yes or no checklist.
Because they just give it to you organically.
Exactly. You learn about their home environment, their support system, their pain tolerance. Giving them the floor makes the consultation significantly more efficient because you are finally operating on the true diagnostic target from the very beginning rather than shadowboxing with a rehearsed script.
Okay. So we have built the architecture. We arrive and sit, we use their name, we acknowledge the context, and we offer an open invitation. None of these four elements take more than 10 or 15 seconds to execute.
Extremely rapid.
But combined, they fundamentally reshape the physics and the power dynamics of the encounter. However, knowing what to do is only half the battle. We also need to be acutely aware of what we are doing wrong without even realizing it.
The habits we fall into.
Right. Our text refers to these as the silent saboteurs. These are the small, pervasive, deeply ingrained habits that quietly undermine the entire consultation, regardless of how brilliant your surgical skills are. Let's examine four specific saboteurs. The first one is looking at the screen first.
This is perhaps the most ubiquitous, insidious clinical error in modern medicine.
The computer.
The electronic health record, the EHR. It has evolved into a massive physical and psychological barrier in the consultation room. Picture the scene. A clinician walks in, sits down, and immediately turns their neck to stare at the computer monitor, clicking the mouse and scrolling while the patient is attempting to explain their symptoms.
I can picture it perfectly. It happens in every hospital.
The nonverbal message being broadcast is devastatingly clear. It says, the data in this machine is vastly more important to me than the living, breathing human being sitting on the examination couch.
It reduces the patient to a mere data point.
Exactly.
And the patient just sits there watching the side of your face.
They watch you read about them rather than engage with them. It is profoundly alienating. We must rigorously train ourselves to separate the human interaction from the data retrieval.
How do we balance that practically? We need the data.
We do need the data, but the screen should only be engaged after the human connection has been solidified through the microelements we just discussed. Walk in, sit down, make eye contact, listen.
Do the human bit first.
Yes. Only when you need specific data should you say, I'm just going to look at your scan results on the screen now, thereby narrating your transition to the technology rather than letting the technology hijack the human interaction.
Narrating the transition. That's a great tip. Now, the second silent saboteur is the fake apology. I see this, and if I'm honest, I've done this constantly.
We all have.
It is the act of saying, sorry for the wait, while simultaneously rushing into the room, looking down at a stack of notes, pulling out a chair, and logging into the computer. It is a verbal reflex. It's not a genuine apology.
A reflex apology is entirely devoid of emotional resonance, and patients are highly evolutionarily attuned to authenticity. They can spot a fake apology instantly.
It's insulting, almost.
It is. When you toss an apology over your shoulder while typing your complex alphanumeric password into the system, it sounds dismissive. It sounds like a mandatory corporate customer service script. Your call is important to us, please hold.
Which just winds people up.
It angers them further because it invalidates their actual frustration. True acknowledgement requires a complete cessation of other activities. It requires that half-second pause, direct, sustained eye contact, and a sincere, grounded delivery.
So stop moving.
Stop moving. I'm sorry I kept you waiting today. Full stop. Silence. Let the acknowledgement land in the room. That tiny pause validates their experience. The reflex apology, conversely, simply signals that you are trying to rush past their inconvenience as quickly as possible to get to your agenda.
That distinction between a reflex and a true acknowledgement is vital. Now, the third saboteur is something we hear constantly in every corridor, in every clinic.
Yeah.
The how are you trap.
Oh, this is a major issue in British clinics.
We are heavily advised against using how are you as a greeting. Now, on the surface, this seems utterly counterintuitive. Why is asking, how are you, such a terrible clinical practice? It seems like the most basic, fundamental human politeness.
It is basic social politeness, and that is precisely why it fails spectacularly in a clinical environment. When you ask a patient, how are you inadvertently trap them in a complex cognitive bind.
Because they don't know which rule book to use.
Exactly. They are forced to, rapidly, in a fraction of a second, decide which set of societal rules applies to this specific interaction. Do they treat it as a social formality, like passing an acquaintance in the supermarket?
Right.
If so, the ingrained British social script dictates they must answer, "Fine, thank you, and you," even if they are currently experiencing an 8 out of 10 radiating sciatic pain that kept them awake all night.
You've just forced them to lie to you in the first 5 seconds.
You have, which immediately complicates the history-taking. They have established a baseline of fine that they now have to backpedal from.
I'm fine, except for the agonizing pain in my spine. It makes no sense.
It makes no sense at all. Alternatively, they might interpret "how you" as a serious, open-ended clinical question. But it is so broad that they are entirely unprepared to provide a concise, medically relevant answer.
So they just ramble.
This leads to confusion, stammering, and a stuttering, unstructured start to the history. It is a deeply ambiguous prompt. We must replace it with the specific, focused, open invitations we discussed, such as, "What has been on your mind regarding your recovery since our last appointment?"
It removes the social ambiguity entirely.
It clearly signals a transition into a focused, safe, clinical reality.
That makes complete sense. The ambiguity is the enemy of efficiency. The final silent saboteur our text mentions is jumping the agenda.
Skipping the pleasantries entirely.
This is the clinician who walks in, doesn't sit down, looks at the chart, and immediately declares, "Right, today we're going to discuss your blood pressure." Or, "Okay, let us look at the range of motion in that knee."
Straight to business.
You are skipping the human beat entirely, and what we are learning is that by skipping that brief, 10-second human beat to supposedly save time, you are essentially generating 20 minutes of friction.
False efficiency.
Exactly. The patient hasn't had a chance to settle, they haven't had a chance to express their primary concern, and now they feel steamrolled by your clinical agenda. By slowing down for just 10 seconds at the start, the rest of the visit actually speeds up because you are working with the patient, not dragging them along behind you.
It is the ultimate paradox of clinical time management. The compulsion to rush is driven by a desperate desire to be efficient. Yet, skipping the foundational human connection is the most inefficient action you can take in a hospital.
Because it creates resistance.
If you jump the agenda, you will spend the rest of the consultation fighting against a strong undercurrent of patient resistance, confusion, and unvoiced concerns. They will be distracted, they will not absorb your instructions, and they will likely require a follow-up appointment to clarify things they missed because they were emotionally overwhelmed.
So slowing down is actually speeding up.
Slowing down to execute the architecture of entry aligns the patient and the clinician on the exact same vector. Once aligned, the actual clinical processing, the physical examination, the discussion of the imaging, the shared decision-making regarding surgery occurs with remarkable speed, clarity, and mutual trust.
Which brings us to the most important part of this entire discussion, implementation.
How to actually do it.
We have theorized, we have analyzed the neurobiology, we have broken down the architecture, but how do we actually change our behavior tomorrow morning in a busy clinic? The proposal from our material is a highly specific 7-day clinical experiment.
Very practical challenge.
The exercise is to physically write down your ideal first 60 seconds in your own words, incorporating the 4 microelements, the physical arrival and sitting, the use of the name, the context statement, and the open invitation, and then commit to using it deliberately for a single week.
The mechanics of adopting this are fascinating because it confronts the harsh reality of behavioral change in adults.
It's hard to change habits.
It's incredibly hard. When you write this script down and attempt it on a Monday morning with your first patient, it will feel intensely artificial.
You'll feel like a fraud.
You will feel as though you are a terrible actor reciting lines in a play. Your mouth will feel clumsy, and that is perfectly normal. Conscious behavioral change always feels artificial initially because you are actively overriding years, perhaps decades, of ingrained unconscious habits.
Habits formed under pressure.
You are overriding the accidental opening you've drifted into throughout your career, which was likely forged in the fires of burnout and exhaustion. But you must push through that initial discomfort. You must accept the artificiality for a few days.
And what happens if we do? What is the compounding effect of this 7-day experiment on the clinician themselves? Because let's be honest, we're asking an exhausted workforce to do more work. What is the return on investment?
Well, by Wednesday or Thursday that week, the artificiality begins to fade. The sequence starts to map onto your existing clinical persona. By Friday, it will begin to feel deeply natural. The long-term return on investment here is profound, not just for the patient, but for the physician's survival. Your patients are not going to suddenly applaud and say, "Doctor, your micro-elements of entry were absolutely flawless today."
They won't notice the mechanics.
They will not possess the vocabulary to describe what you did, but they will leave the room feeling fundamentally different. They will feel respected, heard, and safe.
And for the clinician?
For the clinician, the compounding effect is transformative. Because you are establishing a bedrock of trust instantly, you will extract more accurate clinical information much faster.
Which makes the medicine better.
Precisely. Those incredibly complex, emotionally fraught conversations discussing severe surgical risks, explaining a failed procedure, or navigating palliative care will become significantly less difficult because the foundation of trust is unshakable. They know you see them as a human being.
You're not fighting them anymore.
And crucially, by eliminating the constant friction of resistance, defensive posturing, and miscommunication, you will leave every single consultation room slightly less drained. Over a clinic of 30 patients, that conserved energy is immense. You are replacing the exhausting adversarial process of managing an angry patient with the energizing collaborative process of practicing actual medicine.
That is the ultimate goal, isn't it? The objective of all this structure is not to sound like a programmed robot reciting a corporate customer service script.
Absolutely not.
The goal is to craft a deliberate, highly effective, polished version of your own unique clinical persona. It is about actively replacing the accidental, rushed, perhaps slightly burned out version of yourself that you may have unconsciously defaulted to over the years with a designed, intentional presence.
Precisely. The opening you painstakingly design and practice in week 1 is the exact opening you will still be executing flawlessly 10 years from now. Only by then, it won't feel designed or effortful at all. It will simply be who you are as a clinician. It will be the hallmark of your professional mastery.
Okay, let's bring this all together. We have covered an immense amount of ground today. The core thesis of our discussion is unequivocal. The first 60 seconds dictate the entire trajectory of the clinical consultation.
They set the stage for everything.
Treating this opening as a structured, designable architecture rather than dismissing it as a vague, optional soft skill replaces exhausting processing with actual effective medicine.
Exactly.
We explored the neurobiological reality of the unseen preamble the patient brings into the room. We detailed the 4 vital microelements of physical arrival, naming, context, and open invitation. And we exposed the silent saboteurs like the EHR screen and the fake apology that quietly undermine our bold intentions.
And the practical application is clear.
Yeah.
Write it down, practice it deliberately for 7 days, push through the artificiality, and watch the friction in your clinic dissolve.
I want to leave you with a final provocative thought to ponder as you prepare for your next clinic. We have just demonstrated, through evidence in psychology, how a simple, deliberate change in your physical arrival and a 10-second acknowledgement of context can completely alter a patient's adherence to a complex treatment plan and drastically reduce your risk of a malpractice claim.
It's a huge shift.
If that is true, what other seemingly mundane administrative moments in your daily practice are actually hidden opportunities? Perhaps the way you dictate a referral letter in front of a patient, or the exact phrasing you use when explaining a surgical consent form, are these actually highly potent clinical interventions just waiting to be deliberately designed.
It is certainly worth considering.
It really is. If today's discussion sparked a change in how you view your consultations, please take a moment to rate and share Deep Dive Ortho with your colleagues. Thank you for joining us for this deep dive. We will see you next time.
Thank you. It has been a privilege.
Remember that patient waiting 25 minutes with a dying phone battery and a rising heart rate. The next time you walk up to that consultation room door, remember, the first 60 seconds are entirely yours to design. Make them count.